Good evening. I'm Dr. Hung Vu, and our show is America's Healthcare Crisis. Joining us tonight are three distinguished guest speakers, all of them prominent practicing physicians in our community. Dr. Robert Burnett, MD, practices emergency medicine at El Camino Hospital in Mountain View. He was the past president of the California Medical Association and also was the founder of Lifeguard insurance company. Dr. Jay Crossan is a pediatrician and is affiliated with the Kaiser Permanente, where he holds the function of Associate Executive Director. Dr. Joseph Cook is a family physician. He practices in San Mateo and is currently the medical director of the Aetna Health Insurance Group of Northern California. Tonight's program is intended to give our viewers some information in regard to what is being done and else what could be done to improve the efficiency of our healthcare delivery system, as presented by three expert panelists who hold important functions in the three major existing health insurance programs in Northern California, namely Lifeguard, the Kaiser Plan, and the Aetna Health Plan. Dr. Burnett, welcome to our show.
It's a pleasure to be here and talk with all of you about some of the problems in our healthcare system and give you a little background also about Lifeguard. Lifeguard was started about 11 years ago as an effort to provide another competitive mechanism in the healthcare delivery system of this area. It was to provide a prepaid comprehensive plan using the basis of fee-for-service and using physicians in practice to review and make the decisions to make the delivery system more cost effective. It did allow and does allow a wide choice of plans by the wide choice of physicians by the patients, and has grown to involve over 3,500 physicians and something like 23 hospitals in 11 counties. It's continuing to grow, has over 130,000 enrollees, and I think has had an ameliorating effect on the rise of the cost of medical care, where at the same time, by providing a fee-for-service system, which has the incentives for the physicians to see the patient, provides for an alternative and helps maintain the pluralism that's necessary in our society. We're proud of the plan. We have, I believe, the lowest overhead of any plan in the state of California, except for Kaiser, which does a little better than us, perhaps due to the size of the plan and the savings that can be done in a bigger organization. But we're not here just to talk about the health plan. I really think that what we have to look at are the changes that are necessary to be made in the healthcare system in the United States. And I want to emphasize that what I'm saying does not represent the Medical Association, does not represent Lifeguard, which I am no longer the CEO of, but are my thoughts from experiences in the healthcare delivery system. I think it's essential that the delivery system not be governmentally run. The government has a very important role to play to see that disclosure is fair, certain regulations are enforced, but as far as running the delivery system, I think, as has been found in many countries of the world, it would be a disaster. Certainly, private industry is more efficient. I believe that there should be competition between managed care plans, but in order to have that competition, things have to change to some degree. It's important to develop what are called practice parameters so that physicians who treat people in a certain way are insulated against frivolous lawsuits and therefore do not have the necessity to practice defensive medicine. We have to expand and develop an RBRVS, which is a fairer way to compensate physicians. We have to see that the playing field is leveled. Presently, we have 3 organizations in the state of California, all with different rules. We have ERISA plans, immune to any state regulation, insurance plans, and plans of the Corporation Commission. I might add that the only state in which competition has really worked well is in Hawaii, where access to care is available to all. The principal reason is ERISA plans are not allowed. We can go into all that later in more detail. We have to see that the hospitals concentrate on making their hospitals efficient, such that Hospital A charges the same price to all its customers, Hospital B charges the same price to all its customers, and the hospitals compete on their prices and their efficiency, not on how much they can discount to the biggest player. We have to continue our efforts to reform Medicare, such as the AMA is trying to do. For the present financing of Medicare is on quicksand. We have to change this cross-generational financing and have people that are more well-to-do in the elderly years take more responsibility for their health care. We have to nationalize the Medicaid system such that there's a national program for Medicaid with uniform benefit structure, at the same time bifurcating it to see that the long-term care aspect of it, which is very important, but which is a social program, not be mixed in with the medical program of Medicaid. And lastly, we want to see, we may have to come to the point where the individual is the individual with health insurance, not that the health insurance is through the employer, but each individual is given tax credits, employers are given incentives to provide money for the medical care insurance, and we develop risk pools for those that are in between the poor covered by Medicaid and the working. And in this way, I think we can, using those 10 points, I believe we can preserve a pluralistic system, avoid the pitfalls of governmental control. But each and every person involved in the medical care system will have to give up something. Thank you.
Thank you very much, Dr. Burnett, for your insight and knowledge. Dr. Crossan, Kaiser, the big brother of all the HMOs, how is he doing?
Well, Dr. Vu, I think I can tell you tonight that Kaiser is alive and doing very well.
Great.
We're going to be talking about the healthcare crisis. And I thought it would be interesting to start off with a quotation from the New York Times. And this is from the President of the United States. "We face a massive crisis in healthcare costs. Unless action is taken within the next 2 or 3 years, we will have a breakdown in our medical system." Now, the year was 1969, and the President, Richard Nixon. We have a crisis in medical care in the United States, but it's not new. It's also not temporary. American companies are losing out to foreign competition, and part of the reason is the cost of health care for American workers. At the same time, 35 million Americans at any one time are without health care coverage. The best of American care is the best in the world, and yet every year it gets more and more expensive, and at the same time every year less and less Americans can afford it and have coverage. Kaiser Permanente and other managed care organizations have been working for more than 25 years to try to solve both parts of the healthcare crisis. I'd like to talk for a few minutes about Kaiser Permanente and talk about the reasons I think why we're special, and also some of the problems that we have to solve within our own organization. 5 million Californians belong to Kaiser Permanente and have done that by active choice, decided to join our organization and to stay with us. One of the reasons I think that we've been successful over the 40 years that we've been in existence is because doctors, physicians, have a full-time role as managers in the organizations, and our physicians know that they will have the opportunity to influence the decisions that affect the patients that they take care of. We have what we call integrated facilities. Our doctor's offices, hospitals, and laboratory and x-ray facilities are all in the same place. We even have our pharmacies together so that the patients, when they come in, can get all of their care hopefully taken care of in one visit, one-stop shopping, if you will. We also believe very strongly in comprehensive benefits. Our physicians are more comfortable practicing in the program because they realize that all essentially of the reasonable needs that the patients have are covered and will be available to them to deliver to the patients. We have an advantage because of our size in volume purchasing. We're the largest buyer of pharmaceuticals in the United States. And because we're large, we can pass through the savings to our members, much as the Price Club or other retailers can do who buy in large volume. We have problems also. One of the problems is related to our size. Because we're so big, we can look impersonal and even uncaring. Nothing is further from the truth. The vast majority of our patients, our members, receive their care from a personal physician. I'm a pediatrician, and I took care of patients from the time that they literally were born in the delivery room through high school. We have some difficulties in the speed of delivering appointments, particularly for routine care. We're aware of that, and we've been working very hard for the last 3 years or so to try to improve that. We've hired here in Northern California, the Bay Area and Sacramento, in the last 3 years about 1,000 physicians, 400 or so of whom have come from private practice into our program. And we hope that we will successfully address some of the issues about appointment availability and the speed of that to deal with what our patients need. We have a problem of visibility, which is due to our size. Anytime there's a problem with any physician or individual who works for our organization or at any one of our facilities, it's a Kaiser problem. I was at Stanford yesterday at Frost Amphitheater, that nice outdoor amphitheater, listening to a comedy show with my family, and I was horrified because right after the Dan Quayle jokes, one of the comedians took off on a series of Kaiser jokes. The funniest part of it was, I think to me, and it pointed out the problems of being a large organization, after the Kaiser jokes, the comedian went to Bank of America jokes and introduced the Bank of America as the Kaiser of banks. In fact, what Kaiser Permanente is 35,000 people, doctors, nurses, x-ray technicians, and other individuals trying very hard to deliver to our members what we promise, which is quality care at a reasonable cost.
Thank you, Dr. Carson. Dr. Cook, I have been, as a primary care physician, attracted to the concept of managed care. Maybe you can tell us about that at Aetna.
I'd be happy to do that. I'm a family physician who has practiced for 25 years, and for the last 3 years I've been a medical director, first for Bay Pacific and now for Aetna Health Plans of Northern California. And doing that, I've been involved with managed care. Managed care is a relatively new term, but actually it's something that's been around a long time. The conscientious primary care physician who looks out for patients, tries to make sure that they see the right specialist, make sure that they get the right tests but don't get tests they don't need, is practicing managed care. Managed care has become a name to describe a system where the entrance to that system is through the primary care physician, and the primary care physician, working in concert with the patient, sees that care is managed so that it's done in an efficient, cost-effective way. As I've thought about managed care, it seems to me that the two main ingredients to practice efficient care, first is organization, and secondly has to do with incentives. And we have some real problems right now in an organizational sense, because the base foundation for managed care is primary care physicians. And primary care physicians are in trouble right now for a variety of reasons. At the medical school level, most of the students tend to go into specialties. So there's a shortage of primary care physicians to begin with. In Northern California, and particularly the Bay Area, where I have practiced in San Mateo and San Francisco, the primary care physicians are having particular problems because their incomes are dropping, their overheads are rising, their administrative costs are increasing, and they're really almost an endangered species. The older physicians that are getting ready to retire are having a very difficult time replacing themselves. So that's something that concerns me very much, and that really has to do with organization and also with payment mechanisms. There are way too many specialists, maybe twice as many specialists as we need, and because there are too many specialists, the payments to specialists tend to be too high in a relative sense. And so one of the fundamental organizational things that needs to happen is we need to produce more primary care physicians, we need to make it more attractive for them, we need to have fewer specialists. And that, I think, can be done through various kinds of incentives. It's always seemed to me that when you try to regulate something, you tend to make it worse. When you make sure that it's structured correctly, and at the same time that the incentives are in place, then it tends to work better. And so my thesis about medical care is that you first organize it correctly, and secondly, make sure the incentives are right. And right now we're not organized correctly. And much of that is the shortage of primary care physicians and the oversupply of specialists and the fact that hospitals have not been able to participate in solving that problem.
Thank you very much. Thank you all panelists for your insight and information, which is obviously very precious to all of us. In the second half of the show, I'd like to have a few questions for all our panelists. The first question will be addressed to Dr. Burnett. I'm sure that the Lifeguard plan, the Kaiser plan, the Aetna plan are all excellent health coverages, and the patients who have them are very lucky. However, what do you think our society could do to make such care more accessible to the less fortunate, such as the unemployed, the elderly, and the poor?
Well, I think taking each category by itself, take the elderly first. The AMA, for instance, has had a bill in front of Congress that changes Medicare. Medicare now, as I previously mentioned, is on very poor functions in a very poor financial basis. That is a cross-generational transfer of funds. When Medicare first started, there were 13 working people for every recipient, and now there's about 3 working people for every recipient. This drains the funds from those working to pay for those retired. We have to change that and make it into a forced savings program, allow the people to have an annuity build up from their savings to purchase one of the managed care plans when they reach Medicare age. In the meantime, we're also going to have to provide some type of means testing, such that the elderly that are more affluent at the time of retirement bear some co-payment and some additional payments than those that are not so fortunate in their working years. This, of course, is being vigorously opposed to the AARP, which I've met with back in Washington. And their basic philosophy is it's silly to save your money when there's an inflationary process going on, which I think is a very detrimental attitude for the country. So we have to reform Medicare. We have to develop a basic benefit package, and I forgot to put that in one of my points, and that's got to be for Medicare, Medicaid, and all those employed. This basic benefit package would be one in which those working would get a tax deduction to pay for, Those unemployed would be able to participate in a risk pooling plan, and Medicaid would also have those benefits. The Medicaid program needs to be nationalized, so there's a single benefit program for Medicaid recipients across the country that has this basic benefit package in it. The present Medicaid program is different in each state, and is a good portion of it is used for a social program that is long-term care, which has nothing to do with medical care, and I feel should be bifurcated and put in a separate category so that we know which care we're financing. Would be my feeling that the Medicaid portion of medical care should be nationally throughout the country, and the long-term care be up to each state. And lastly, as I inferred, the unemployed or those employed in jobs with low incomes and who do not qualify for health insurance of any kind should be part of risk pools, and employers that do not pay any type of stipend to go toward the health insurance should be required to do that. Now, I know that increases costs, but it increases costs mainly to small employers, not to the ones that are competing in the world markets. And we have to cut down stop the rise of medical care costs. We're competing in a world in which, as Dr. Carson said, we have a situation where Japan spends, I believe, 12% of its gross national product in education and 6% in medical care. We spend 6% on education and 12% in medical care, and you can imagine where that's going. So I think with altering these systems, getting a basic benefit package, having sound financial mechanisms, having these other things that I said to create competition in an even field, and then once you get an even field competition, to reimburse the plans according to the risk they take, the demographics of their enrollees, so that we can change our competitive system, which is now one to try and enroll as many healthy people as you can, to a system where all of our plans compete on how well and how efficiently and what are the outcomes of care of our plan. We can do it. It's difficult. Everybody's going to have to give up something.
Thank you. Thank you for your opinion. Dr. Carson, in regard to malpractice, it has been my observation that the medical profession has been taking the defensive position. In other words, we order a lot of unnecessary tests and procedures and take an inordinate amount of time documenting charts. And all of this at the expense of cost containment and direct communication with the patients. Do you think we as physicians should take a more active role in the process of educating the public and or confronting the legal profession in this issue?
Well, Dr. Vu, to some extent in Kaiser Permanente we have done this. For the last 15 years or so, we have been using binding arbitration as a way of reducing the costs from medical liability claims. And I think it's been fairly successful. We still have significant costs in that area, but we have at least changed the incentives and removed the incentive for individuals to bring claims that are not justified. I think that actually the issue with medical malpractice claims rests with the doctors. The most important ingredient we have found in determining whether or not there will be a lawsuit resulting from an injury or a bad event in medical care is the trust between the physician and the patient. And to a great extent that has to do with the adequacy of the communication that has occurred between those two people as individuals. And I think where physicians have work to do is in the process of developing a trust relationship and communicating to the patients the information that needs to flow between them. And we find when that breaks down, that's when you end up with difficulties in the medical malpractice arena. And so we have worked, and are continuing to work very closely with our physicians to work with them on their communication skills, particularly, and on the process of documenting in the chart the communication that has taken place. And I think that's the area that we should most properly address, and the area that will ultimately result in the costs of these malpractice claims being reduced down to a minimum.
Dr. Cook, prevention is a popular word these days, and I'm glad it is, but does prevention really pay? What I mean is that do you foresee a day when the people who do not smoke, who do not drink, and exercise regularly are going to be entitled to a lower health insurance premium?
I would hope so. I certainly believe in incentives, and it's interesting that the things that make the most difference in terms of prevention are mostly things that a person can do on their own. As you indicated, if you stop smoking, or if you avoid excessive alcohol or drugs, keep your weight under control, eat a balanced diet, exercise regularly, those are the main ingredients, and I think people who do that ought to have some incentives to do it, and I also think physicians ought to have incentives to help their patients stay well and keep them out of the hospital, because that's where the big expenses occur.
I'm glad to hear that, especially from you. Anyway, we're running out of time. Ladies and gentlemen, you have just heard from our expert panelists some very important information in regard to what is being done, or else what could be done, to improve the efficiency of our healthcare delivery system. On behalf of the production staff of America's Healthcare Crisis and Channel 30 Access Los Altos, I'd like to thank all of them for taking the time off their busy schedule to be here with us tonight. Again, our program is intended to provide a forum for the expression of ideas that might help in improving the efficiency of our healthcare delivery system. And we'll welcome any suggestion you might have in regard to the topics you would like us to cover, or the speakers that you would like us to invite to appear on our show. To write to us, please use the address on the screen, and check the schedule in the Los Altos Town Crier newspaper for the time and dates of our future productions. Thank you for watching. I am Dr. Hung Vu. Good night.